Okay. Yeah. Hello, good evening, and we welcome you to this webinar rooted in realities focused on the margins, building public health for tomorrow. I'm Bevin. I'm a faculty member at Azim Premji University, Bhopal. And this is a part of the webinars that we do to build conversations around public health. We also have an upcoming talk, which is called as Let's Talk Public Health series, where again we talk to different practitioners. So today I have with me Mayur Trivedi, who's also faculty member at the university. I'll just give a brief introduction about Mayur. Mayur has about 2 decades of experience in public health, both as a teacher and researcher. He works in the broad areas of healthcare financing, health and development issues, and assessment of health interventions, to name a few. Mayur also has a radio channel at Radio Azim Premji, just called Likhe Jo Kat Mujhe, where he discusses perspectives from different people whom he encountered in his journey of public health in the form of letters written to him. And for those of you who are interested, you can check it out on the Radio Azim Premji website. So today for this webinar, we are discussing a very important and a relevant topic in public health. So when you look at public health in India, we have come a long way in terms of improving coverage of different services, multiple infrastructure, and multiple health outcomes. So taking this example of underweight among children, in 1998, we see that from NFHS2, that close to around 43% of children under 5 years of age were underweight. And this has reduced to about 32% in 2021, as per the latest estimates of NFHS 5. So when you look at this reduction, it's not uniform across the groups in the population. So currently about 27% of children in urban areas, they are underweight when compared to about 34% in rural areas. And we see that a similar kind of a gap exists by caste as well as wealth groups. And the outcomes are not the same. So who are these groups that are left behind? Why are health outcomes and indicators not the same across groups in the population? And how can we build a public health for tomorrow, which in the true spirit is leaving no one behind? So Mayur today will be broadly speaking about this in this webinar, and we hope that this will be an enriching session, a time of discussion and learning about the topic, especially for those who are new to the field of public health. And we also get to learn from Mayur's experience. So I'd like to remind the audience that we have a chat box which is running. We request you to please keep your questions coming, and we will take them up after Mayur's talk. And we'd all like to hear from Mayur on this very important topic. So without taking much time, I would like to hand it over to Mayur. Over to you, Mayur.
Thank you, Bevin. I hope I'm audible. Thank you for joining us at this webinar on Azim Premji University. Can I have my slides up, please? Thank you. So as Bevin indicated, the title of today's discussion is Rooted in Realities Focused on Margins, Building Public Health for Tomorrow. Before giving the outline of the talk, let me introduce myself through a detailed journey through which I can tell about my 2-decade plus work journey. Not to really boast about what I have done, but many of us who have joined today could be public health aspirants or young public health professionals. It would be useful for them to see and appreciate what I call a very atypical public health journey. I did my diploma in pharmacy first and then degree pharmacy between 94 and 99. Spending 6 years for my graduation, I realized that pharmacy is not the field that I was enjoying much. So I took a route away from mainstream paraclinical courses and went on to do my master's in health management between 2001 and 3. This was at IIHMR Jaipur. These 2 years have fundamentally changed not only my career trajectory, but also changed the way I saw the world. I entered into academia, was a research associate to begin with at Health Policy Research Unit at Institute of Economic Growth in Delhi. Spent fantastic 5.5 years there, and in between registered for my PhD, which I got from Faculty of Management Studies in Delhi University. The journey at IEG, Health Policy Research Unit, under mentorship of Professor Indrani Gupta, was heavy into learning, and I needed an outlet. That's where I joined Indian Institute of Public Health, Gandhinagar, one of the institute established by Public Health Foundation of India, primarily because of elements of teaching that was available. I was founding faculty there and continued to serve there as a faculty. And after spending 15 years and teaching postgraduate diploma in public health management, as well as masters in public health management and masters in hospital administration students, little around 2 years ago, I joined Azim Premji University, where the MPH program was just started. In these little more than 2 decades, I had the opportunity to work on a range of issues. Some of this Bevin already mentioned, so I'll not get into details. But why I'm sharing all this is it can give us an idea of how multidisciplinary and interdisciplinary public health career can be. And I always say that my name is Khan and I'm not a terrorist. Similarly, I'm a public health professional and not a doctor. This field is fantastic. It's full of people like me who need not necessarily treat patients, which is commonly healthcare is known as, but can have a range of experience of working on diverse thematic areas, diverse population, and a wide range of collaborators, as you can see on the slides. I have not worked inside UN agencies, but I have worked with almost 5-6 agencies. I have worked with many state governments and also had an opportunity to work with government of Bhutan and Nepal. Having said that, my interest always remained with margin, the last mile. I had fantastic opportunity to work with the communities who live deeper inside wildlife protected areas, Little Run of Kutch and Gir Forest. So what I'm going to talk about today is coming from that interest on focusing at the margin. My little journey is important because it can give that idea of how a range of public health today is and can be much more tomorrow. So what I'm going to talk about in another 20-30 minutes has broadly three sub-themes, if I call it that way. We'll start with talking about public health yesterday and today. In that, we'll broadly try and understand how much improvement we have made globally and in India in terms of range of health outcomes with some specific examples. But while we have made a massive outcome at the average aggregate level, we'll also try and appreciate when we look at disaggregated data, there are certain sections of society have been left behind. So we'll try and understand who is left behind while the aggregate health outcomes have improved. Taking cue from who is left behind, we'll try and understand the concepts around what we know as margin and marginality, and also the process of marginalization. Why do some space, people dominate attention and power, and how certain sections of the societies are left behind? And I want to end my talk with emphasizing on those who have been left behind needs to be our attention for public health for tomorrow. So while aggregate improvements have happened, what more needs to be done to ensure distributive justice? How can we be more equitable in our actions, ranging from policy to programs? And to do that, how we can train next generation of public health professionals differently. These are broad three subsection of my talk that's going to be. And as Bevin indicated, please feel free to uh, let your questions in through chat box, and I would be happy to uh, take them up. And this could be questions, comments, suggestions, and it would be very useful for us to have an interactive time at the end of this webinar. So let's start with public health yesterday and today and understand who has been left behind. On your screen, you see two pictures. On your left is a kind of a child which I have never seen in my life, because smallpox was eradicated uh, exactly on the year that I was born in. So my generation of public health professionals, or my generation of any professionals in my entire generations, may not have seen a child with smallpox. On your right are children with poliomyelitis. My students of public health, which I have been teaching in last 15 odd years, may not have seen a child with polio, because polio has also have been almost on the verge of eradication across the world and in India also. The world has conquered these two diseases which were killing millions of children and also creating debilities in another millions. This is fantastic improvement, and all this have happened in last 200 years. Taking it a little further, on your screen you may see three different maps. If you're using mobile phone, it may be difficult for you to get micro details, but I'll help you walk through it. On top of the first map has all red color, which basically means child mortality across the world in year 1800, some 225 years from earlier than today, had one third of children dying before reaching their fifth birthday. We had 10,000 plus years of agriculture and human civilization. We could not reduce child mortality to great extent. In year 1800, every third child across the world was dying before their fifth birthday. Fast forward that by 150 years, the second map in middle tells us what was the situation in 1950, little around our independence. As you can see, Europe, America, Australia are all in green. Green would mean less than 10% of child mortality. Yellow, Russia, part of South America are all yellow, which means less than 20% of child mortality. When India got its independence, around the same time, many Asian and African countries also got independence. The problem of high child mortality was a chronic problem only in Asia and African countries. And if you fast forward that by another 65 years, the map at the bottom tells us that child mortality is virtually non-existent in Europe and America and Oceania, the Australian country, a country around Australia. Blue is less than 5%. The big news in last 60 odd years is that Africa and Asia also made spectacular improvements, and our child mortality is way below what it was a few hundred years ago. So 200 years of a journey tells us massive health outcomes from almost every country having more than 20-30% of child mortality to less than 10% of child mortality. This is a significant improvement, because we did not have such health outcomes for ages since humanity's existed. India also saw quite spectacular improvement on an aggregate level. India's child mortality was around 200 when we got independence. It's 40 now, which means every fifth child was dying before its fifth birthday. Now, around 4% children have this ill fate, which means who are born are living longer. They survive through their childhood, and highly likely they will survive through their adulthood as well. Our average life expectancy at birth during independence was in 30s, around 31, which has increased to 72 as we are talking. These are significant improvement. The world has seen significant improvement. India has also seen massive health outcomes and its improvement. However, there is a problem. The problem is that of a huge disparity. Slightly bulky slide, but I'll help you walk through it. If you take your attention to the right side of the screen where I'm posting you life expectancy at birth year in terms of years, we saw our life expectancy has improved, but the level of improvement is different by different categories. While the wealthiest 20% have around more than 70 of life expectancy in 20, the poorest has gap of 11 years, which by no means is a simple gap. Poverty is not the only problem. Upper caste, which is what we know as general category, has 68 life expectancy, while our SC and STs are in 60s. If I take your attention to your left, where we are talking about malnutrition, something that Bevin mentioned while he was introducing this webinar. Among the wealthiest, only 22% children are stunted. And this is very recent data, National Family Health Survey Round 5, 2019-21. While proportion of children who are stunted among the wealthiest 20% is just 1 in 5, every second child among the poor is stunted. The stunting is very, very high, especially among Dalits and Adivasis of India. Together, this has an influence on child mortality also. And as you can see, child mortality among rich is only 20%, 19 to be precise, while it's very high among Dalits, Adivasis, and the poor, in the tune of half and more than half of the child dying before their fifth birthday. While we have all the reasons to celebrate improvement at an aggregate level, the scenario when we decode by different social identities, there is a lot remains to be done. This is where we are today. Our yesterday was fantastic. We had spectacular improvement at an aggregate level, but today we are seeing a huge disparity by caste and wealth. These are some indicators, and such disparity is seen across various indicators. So the next generation of public health work is needed to reduce this disparity. And to reduce the disparity, we need to look at the margin. So let's now spend a little time and understand conceptually what do we mean by margins, and why do some people who are from the margin continue to remain marginalized. Three concepts I would like us to focus on: margin, marginality, and marginalization. Margin is very simple. In Hindi, we call it hanshiya, which means space. Now, this space could be physical space or metaphorical space if we are talking about identities away from geographical locations. So, this metaphorical or physical space away from or outside the dominant center of society where power and control and resources are concentrated. So basically, in simple terms, it would mean center and periphery. Center is where actions are happening, there are power and there are resources. Periphery is a space where there is lack of power, lack of control, and scarce resources. So it looks like that margin is a phenomena which is only physical in nature and nothing can be done about it. However, if we understand how does marginalization happen, it's important for us to appreciate that it's not a natural output, it's a process. But before going to marginalization, let's understand what does marginality would mean. And marginality can be multiple. Marginality, in some sense, is a state of being margin, being at the margin. And many times, people who are marginalized by one aspect of their social identity are also at the receiving end of marginalization by many different social identities. And these multiple marginalities are mutually inclusive. And sometimes it's important for us to understand how they intersect with each other. And that's where Crenshaw's intersectionality framework is extremely useful for us to understand. So when some people are born in certain social identities at certain locations, their marginality aggravates because of this intersection of more than one social identities. And how society operates is the process through which these individuals or groups are continue to remain at the margin, which means they are peripheralized. They remain at the periphery, either through policies or through programs or through cultural interactions. They are continue to be pushed to the edges of the society. And this is largely happening because they belong to certain identities, they have certain associations and experiences, and also their locations have ecological, environmental issues. Together, this process ensures that they have limited access to resources, power, and opportunities. Unless these processes are not addressed, marginalization cannot go away. And this limited access to resource, power, and opportunities ultimately leads to deterioration in multifacets, which could be social, economic, physical, psychological, and physiological. Together, all this helps in poor health outcomes of the people who are at the margin. Let's try and understand this in little more detail. I'm sure many of us know SDG, Sustainable Development Goals. At halfway through the Sustainable Development Goal, there is an acknowledgement that there is a lot of disparity exists. And the focus in 2021 went into looking at the margin, ensuring that nobody is left behind. So this report of SDG in 2022, Leaving No One Behind, talked about these multiple marginalities. On your left, you can see a kind of a Venn diagram which talks about 5 types of marginality: geography, socioeconomic status, discrimination, vulnerability to shocks, and governance. I'll not get into micro details of what these are. I'll give you the reference of this document. But ultimately, what it means is people who experience multiple marginalities are generally those who are discriminated against socially. In Indian context, the caste and class, Dalit, Adivasi, poor, minorities, they are the segment of people who are discriminated socially. Traditionally, these people are also those who face multidimensional poverty and inequality. The caste equation in India influences work, and that's how it influences class. Some proportion of poor are very different in, for example, general categories and Dalits and Adivasis. Many times, this segment of society who face multiple marginalities also live in isolated and excluded locations, which means they are physically away from where actions are happening. This physically away could mean different in different contexts. For example, slums in an urban setting are away from where mainstream actions are happening within the city. In a village, you will see different kind of hamlets where Dalits and Adivasis live away from the center of the village. In many cities, you will find ghettos where minorities like Muslims live are also in some sense away from the center of the city. So living in a physical space which is isolated and excluded locations is also part of multiple marginality. Our Adivasi population, for example, continue to live in areas which are predominantly near to the forest, river, desert. Not only these spaces are vulnerable to climate and environmental shocks, many times these spaces are also government regulated sensitive socio-ecological system. For example, Pardi community that we have in many states, especially Madhya Pradesh, Maharashtra, and Gujarat. A denotified tribe which was relying on forests for their livelihood, suddenly their occupation became illegal because forests have become wildlife protected area. So when community owned resources like forest and deserts and hills become government regulated spaces, their marginality increases. Many times these people are also relying on occupations which are primary sector occupations, which means they rely on natural forces like rain, for example. So they are vulnerable to climate change differently than many people who are in secondary or tertiary sector jobs. So when we need to understand margin, we need to understand that margin is not one. There are many kinds of margin, and some people are at the intersections of multiple marginalities, which increases their vulnerability to multifold in many ways. Let's understand this with an example of India. On your right, so what I have done here is one of my earlier work with my colleague Yogita Chaudhary. We uh, divided India's districts by quintiles of multiple MDP, multidimensional poverty index. For each state, we divided states into 5 quintiles based on multidimensional poverty. On your right, what you are seeing is districts where poverty is less, which means they are low multidimensional poverty index districts. In other words, they are better off districts, high development districts. And on the left, you can see the districts with high multidimensional poverty index, which means they are low development, worse of poor districts. If I take your attention to the right first, as you can see, the color coding, better off districts, high development districts, good performing districts are generally located around state headquarters. They are not at the margin, they are at the center of activity, which could be administrative capital or it could be financial capital. In some states, both are same. Like Mumbai is financial capital, Mumbai is also administrative capital. But if you look at the left, the districts in each state which are worst performing, poor districts, high poverty districts, are all away from the state headquarters. By virtue of being away from state headquarters, they are actually at the borders of not only their own state, but from the other states, where they are actually meeting their counterpart from the other states. Look at, for example, borders of Maharashtra, Madhya Pradesh, Rajasthan, Gujarat. All the districts of these 4 states are making a cluster of high poverty, low development cluster. Similarly, we have central tribal belt, where you have borders of Maharashtra, Chhattisgarh, Odisha, um, sorry. Same way, we have international borders, like worst performing districts, for example, of Uttar Pradesh are bordering Nepal. There are cluster of districts north of West Bengal and east of Bihar is making another cluster. Even the marginalized states of northeast India, if you look at by districts, the bordering districts are having poor performance. Now, this is one simple example of geographical marginalization. But these are also districts which are home to forests. These are home to deserts. People who are living in these districts are predominantly tribal. So they are not only away from center of action geographically, they are heavily dependent on ecologically sensitive area and tuned to climate shocks. By being border districts, they are also in some sense punishment posting for government officials of all departments including health, which means their health systems are by and large remain dysfunctional because there are not many stewards, passionate people who are serving the community. So margins at district level, and then within district blocks, and within blocks villages, and within villages certain households, these are different layers of margins that we have, and how certain section of society continue to have poor life in general, and that's how poor health outcomes is what the story of India's development is. We have made massive improvement at an aggregate level, but a lot more needs to be done when we look at the distribution of outcome, and that's where the next generation development agenda in general is, but within that, next generation public health agenda is nested. Taking cue from Ba et al. 2019, the argument is while we talk about social determinants of health, we need to nest SDH, social determinant of health argument, alongside the marginalization argument. So, this conceptual model actually talks about the link between SDH, social determinants of health, and marginalization. So while there is a lot of influence on people's social position across class, occupation, income, gender, residential segregation, having influenced by socio-political economic context, while idea of market and government and culture all influences people's social positions, which together influences what we know as determinants of health. Together, where I am born, where I'm living, where I work, where I grow, is influencing my personal experiences alongside of the various determinants. So the health outcomes of different individuals needs to be seen in context of these personal and societal collective experiences. Unless this realities in which people are born, live, grow, work is not addressed, not changed, health of people may not see major improvement. So public health work, when we say looking at margin and rooting in reality, is this reality that we need to focus on, not only from determinants perspective, but also marginalization perspective. So with that background, I'll now turn to what is needed. Public health for tomorrow may not be the same story that we had been saying since last 2 3 decades. In other words, how I was trained and how I am training my students needs to see a quantum jump, not only in efforts but also in direction. So my next couple of slides and detail that I want to talk about is about how do we train next generation public health professionals differently, so that in another 20 30 years we can make massive progress towards distributive justice. Before talking about how to do that, I'll share my what I call 5S in public health. Public health education needs to focus on 4S, I say. The first S is society. We need to bring multiple realities of diverse lived experiences of different kinds of people as part of our education, be it in the classroom or in the field or in interaction of both. The massive focus of public health education has been on science. We talk a lot of about skills and competencies and knowledge across clinical sciences, sociological sciences, and techno-managerial sciences. And we marry the science very well with system. So a lot of public health education efforts are for introducing our students to policies, programs, and a range of facilities, not only for healthcare but also for social determinants of health. So the marriage of science and system has been the cornerstone of public health education. The 4S on slide is missing, but the 4S is about self. Faculty, students, we as individuals are also intersection of our multiple realities, be it social, commercial, political, or administrative. So we as teachers of public health and we as students of public health and we as public health practitioners are also not in isolation. It's not that the community or society that we work with are they and we are different than them. We are slice of the same society. So more of interaction between self and society is needed to nest how science and system has been working. That is where I think public health for tomorrow needs to be different than the public health of yesterday and today. How to do that? First thing is we need to recognize that there is a marginalization. Once recognition is established, we need to find ways to resist marginalization and then help communities transcend through the marginalization. And this can happen at three levels. Policies and programs, generally, and it's very common parlance that we talk about top down versus bottom up. But it needs to happen in true sense. We need to bring people to the center of decision making. A typical biomedical way of looking at things, especially in health sector, is we treat patients as passive beneficiary. But in public health, when we center our actions by having people at the core, we don't merely treat them, we make them part of decision making at all levels. While there is a lot of discussion on leaving no one behind and looking at the margin, we also need to find what is that, what is marginalized in research parlance. Are certain methods mainstream and certain methods marginalized? Are certain approach to intervention mainstream and certain approach are marginalized? Can we go to people and inquire locally and create contextually relevant methods to do research? Can we find locally acceptable, contextually relevant approach to interventions? This is, I think, agenda for transcending marginalization in the sphere of research and intervention. And last and very important, that's where I belong, because I'm neither a policymaker nor program person. I'm in some sense a researcher, but big way I'm a public health faculty. So the third element of recognizing, resisting, and transcending marginalization involves how do we do public health education differently. Field, classroom field. This, and I'm using the field twice here because I'm emphasizing that these are not in isolation. It's in continuum where we teach something to students in class, they see it in the field, they come back and question what we teach in the classroom with field insights. This loop or this continuum can ensure that not only students, as faculty also, we all learn from the lived experiences of the communities, lived experiences of organizations that live with community, work with community, and also lived experience of students themselves, because we need in our classroom students from the margin, so that we don't just talk theory of marginalization, but we learn from their lived experiences and help change the reality. So, two things are needed to improve public health education by focusing at the margin. We need to understand the reality of margin. The demography of students that I have been teaching, I think that needs to be changed. We need more people from the margin, as I already said. But whosoever is coming to our classrooms, in addition to or instead of talking to them about margins, we need to take them closer to the realities of margin. This can happen by helping students spend time and immerse themselves with urban slum dwellers who are at the margins of social and occupational identities. In cities, Dalits, Muslim, Adivasis, denotified tribes, students must spend a lot of time bring those stories to the classroom, and we help them reflect better and learn from. Students also need to be uh, facilitated spending time with rural remote communities where they live in, especially in the kind of border districts I talked about through map, where there are communities living away from binaries of rural and urban in spaces which are near. And we need to find ways to enlighten or mix this exposure through discussion and experience through immersion. This cannot happen in isolated internships. This has to be immersion, where there is a lot of experience happens. This can be done in two ways. We can bring a lot more organizational experiences from such realities to the classroom. We can invite a lot of experts who are working with these communities, whether they are health professional or not, even if they are working on livelihood, on education, on gender. All these are influencing health as determinants. Bring them to the classroom so that people's lived realities and experiences are part of our curriculum. And it can happen through structured and concurrent field placement with organizations where these experts are. This is difficult task because students need to firsthand feel this hardship of reaching to such locations, spending time there, deal with uh, food, transport related issues. But through that, they will understand how more than one third of our populations are anyways living and where the next actions are needed. The last mile in public health education, and I'll finish in a couple of slides now. We need to revisit the idea of field in public health education. And that's where I say we need to understand the chronology of where are we sending our students. We first need to send our students to society, which means they directly deal with people, understand where they live, understand what they eat, what kind of work they do. And then they should spend time with organizations who are helping this community to live, to work, to grow. And lastly, we should send them to health facilities like hospitals or primary health centers, so that we are helping students to sit by the side of society first and then sit by the society of system. So society should come first, science and system should come later in terms of exposure of the students. Our engagement needs to move away from task driven internships to more of an organizational and community immersions, which means a typical understanding of internship is students need to go and do something. While they are busy doing something, they are losing an opportunity to feel, to experience, to immerse, and learn from conversations and reflections. So, third important point of revisiting field is focusing more on reflections and making meaning out of their experiences. While we are revisiting the field as a public health faculty, I think we also need to revisit how our classrooms are happening. We need to bring a lot more first-hand accounts and grounded worldviews from diverse lived experience of students. While we are making patients as passive beneficiaries of healthcare, I think we are also making students passive beneficiary of our education. That needs to be changed. Our students are slice of the same society we are trying to change, improve. Their own lived experiences can also be very valuable to improve the classroom learning. We also need to move away from content and information heavy classroom to more of context and insight heavy experiences inside the classrooms. And lastly, from merely exchanging information, we need to emphasize on how we can become not only better teacher but better mentor, where we help student ask more meaningful questions. The mentorship can also happen while they are in the field, while we sit with them outside a house of an asha worker, looking at the register and training their sight into looking for right kind of data and understanding right kind of questions. So the next generation agenda are quite a few, and it's for everybody: students, teachers, program planners, and policymakers. First, reclaim the public in public health. We need to begin from and focus on local realities rather than, broadly speaking, imported models, not only of intervention. Many times our texts are also uh, best practice or uh, fantastic research, but we need to find ways to convert them into locally relevant. And also, we need to help students learn from the community rather than just uh, be available for changing the community. The second is the agenda of the university that I am now working, striving for human and equitable society in general, but public health system in at the core. Equity is certainly the foundation, and we need to see entire and everything of public health from equity angle. And we need to always understand that our evidences and actions for public health should be ultimately targeted to ensure social justice. Um, and last, public health education and public health practice needs to focus on values, perspective, and understand that this is also a kind of a politics. While expertise is extremely important, what is important is we integrate with expertise with empathy, ethics, and engagement, where community remains at the center. So broadly, what I wanted to say was this: that next generation public health action is needed differently. That's where community needs to be at focus, and students and faculty need to be more human, empathetic, and need to learn from each other in the classrooms, both students and faculty, but have a lot more learning from community perspective. Thank you so much, and I'll be happy to take questions or have discussions. Bevin, over to you.
Yeah. So thank you so much, Mayur. Just to summarize the talk for our viewers, so it's important that you started with a description about yourself, because it's very important. Given that in public health we largely deal with multidisciplinary issues and also people from different background. So it's important that you brought that up and you spoke about it, and then you spoke about the changing nature of public health globally and in India. And so also drawing upon examples specifically from India on related to child mortality and life expectancy, how there are disparities that are exist across different socioeconomic identities. Then you also spoke and marginalization, and why this specifically matters for public health. So while different axes of marginalization exist, how can we imagine a better public health for tomorrow, focusing largely on and you focus largely on the public health education in India? You very importantly highlighted the 4S in public health: the society, the science, the system, and the self, and how it is important for policies, for research, for intervention, and education. And you concluded by mentioning that the focus should be on the public and public health, on equitable health systems, and importance of value, ethics, and politics. So, thank you once again, Mayur, for this insightful talk. And before I take on questions from the chat box, I'd also like to apologize to the viewers that we're sorry that there's some technical glitch that which requires you sort of to log in before posting questions. But still, I have some. So, Mayur, you have been in this decade for almost in this space for almost 2 decades. So, how has this discourse on margins or marginality, has it changed or evolved over time?
Um, okay. Um, no, it's a difficult question to ask depending on where the discussions were happening. These discussions were always happening in certain fraternity of public health institutes. For example, Center of Social Medicine and Community Health in JNU or Tata Institute of Social Science have always been talking about people who are at the margin. But people who enter to these institutions were also very specific small group of people. Uh, Mainstream public health institutes um, have traditionally been biomedical. MPH programs running, for example, in PGIs or JIPMERs or IIPHs have biomedical focus, and there is less discussion on margins and marginalization. A good blend of development, social science, and public health, like MPH program of APU, is where the discussions are now happening. So it's increasingly becoming more. So I'll put it this way: the discussion on marginalization is becoming more mainstream now, and it's a recent phenomena. But I'm sure it will take a center stage in years to come. I always tell my students that the agenda for you is be very different than the agenda that I had when I passed out 20 years ago.
Yeah, so it's interesting because the reason why I had this question is because before I entered public health, and my understanding of marginality or caste and other things is aspects like untouchability and people arguing or fighting on those lines. So as an health professional, I never sort of imagined that caste or something like that. That is something which I learned in my MPH program. When we are discussing about this entire social determinants of health and other aspects. So that was when it it hit, and actually a realization that okay, caste could also be a determinant of health. By virtue of belonging to a certain identity, you're more likely to fall sick and not recover. And I think that sort of helped me to build a perspective on focus beyond the individual, from where they come, what they do, and how that reality shapes their health. So yeah, that is some learning for me. So the other question that I want to ask you is, like, you spoke about the public health for tomorrow. So now you have been a student. You briefly said that largely in recent times there is a more discussion on about this marginality and marginalization. But in your experience, how have this kind of evolved?
See, in my own journey, a massive learning happened. For example, when I met the students from different social identities at APU, my classroom experience taught me much more than what my research or professional as a professor I was when I was teaching. Um, I couldn't focus much on margins. My students who comes from these realities made me aware of my biases and helped me take a pause and reflect more on society and the sections of society which needs attention. Of course, some research, for example, as I mentioned, I spent time with people who live inside forest and desert. Um, and methods, that was an ethnography method. For example, if I would have gone and did survey, I would not have an immersion and lived the way they lived. So the margins of research method is also an important element. The more we dirty our hands, not only with numbers, but also a lot of narratives by sitting by the side of people, society. That's where I think learning happens more.
Okay, so yeah, a couple of questions from the chat box. So when you're talking about demand and supply, why rural areas are not having health infrastructure though they need it most and there is demand too?
Well, uh, there are two ways to look at it. Rural areas do have infrastructure. It's easy to build buildings. If you remember, if you call infrastructure as buildings and equipments, the contracts happens from state headquarters. So you will have a building, you will have equipments. What you don't have is human resource, especially doctors. So supply of doctors is a problem. But if you look at doctors per thousand population ratio, we are almost there. We have almost reached what WHO prescribes, one doctor per thousand population. For our population, we have enough doctors. Distribution of doctors is a problem. And the same thing happens in society. It's also a reflection. If my determinants of living, if my amenities are not there in the rural area, doctors prefer not to go to rural area. So it's a complex problem. We have a lot of need, but there is a problem of converting the need into demand, and that's where the supply comes in. It's a complex economic problem, uh, which requires actions by both government and non-government. Private sector is highly unlikely to respond to this challenge. That's where the space of government and non-government organization is needed, and that's where most of the career of public health professional is also in this sphere of GOs and NGOs, government organizations and non-governmental organizations.
Yeah. So a follow-up question to that is, can the Ayushman Bharat scheme increase access to public health infrastructure in rural areas?
Um, Again, a complicated, I mean, it can be a long, complicated answer, but simple, straightforward is no. Ayushman Bharat has two wings. Um, Pradhan Mantri Jan Arogya Yojana covers only inpatient expenses for secondary, tertiary care, and these hospitals are generally not in rural area. Um, it can reduce expenses of patient in some way, but there are less evidence that it is doing so. The other element of health and wellness centers, um, I'm mentoring my students in rural Rajasthan and remote parts of Gujarat as I'm talking. Public health facilities are dysfunctional. There are five, the branding has happened, the buildings are there, but they are not able to cater to the 12 prescribed services. So, because again, the problem is making such facilities functional, especially in rural remote areas. But the good part is away from Ayushman Bharat, my students, for example, are working with basic health services and Seva Rural, and I'm sure there are others. You are also maybe visiting similar students in rural Jharkhand or Chhattisgarh. Non-governmental organizations are doing what government was supposed to be doing, and they are catering to the needs of the people. Will it improve public health infrastructure? No. Will it improve health of people in the longer run? Yes.
Yeah. Yeah, I think this is also. I mean, adding to it, there's this discourse on public health. You know, this we have AI now, we have telemedicines, we have technologies which will, take healthcare to the rural, hard to reach areas, and so a lot of discourses there. Although technology is useful and has its own utility, you can't rely entirely on it. The other day I was just one of a colleague who's visiting in the field. He had to call me up in the morning because that is the only time they'll get network and they have access to a network. And we are in 2025 and there are still areas where this technology is yet to reach. Yes, and access is it's very difficult, but we can hope that we reach there where people have access to healthcare. So another question in the chat box is, I think, what education or experience should one have to work in public health?
Oh, Education or experience before entering public health education, I don't think one needs any UG, any undergraduate training, etc. is all fine. Just join the bandwagon, come for spending 2 years of fantastic immersive learning at any public health institution. While you are at the spending this 2 years at a public health course, make your education and experience meaningful by, as I said in my talk, by converting your information into insight, content, connect the content to context, have more of community near experiences rather than classroom experiences, and have a lot of collaborations. Not, I'm not saying LinkedIn collaborations, I'm saying collaborations with people who are working in the field. Those kind of experience near, community near education will make someone more equal than others after completing their MPH.
Yeah. So one last question before we wind up. So a lot of questions related to health communication. Questions on how can we strengthen, more on prevention, how to make it more creative and effective, and a question on how can we improve communication with frontline workers. When we want to talk to them about public health, but also they don't get this feeling that we are teaching them. And how do you engage with them in using effective communication?
Very, very interesting question. And I'm sure you would appreciate whenever we take interviews of public health aspirants, the common thing is people don't have awareness and we need to go and give them information. I think eventually the students would realize that they know little about the community and about the frontline worker in this context. So, how to make communication more appealing is as simple as sitting by the side of people who are receiving this information, making it contextually relevant, um, and not developing materials using internet or AI sitting at the center. Can we go to the community, help them, make us communication which is useful to them? So, a lot more awareness is needed by public health professionals. They need to know their own ignorance about community, sit with the community, remove their own ignorance, and learn from community to help them how to make such tools better. I remember my biotechnology student who had interest in illustration. He was a good painter. Um, he did his internship, dissertation, everything on communication. He joined John Hopkins I think he's just finished his PhD. All of his work was how to make more meaningful illustrations to help people understand better. I'm at Basic Health Service, as I said. They have all of their IEC materials do not have words. They're all visuals. Their health worker also tick marks on a visual rather than writes information in words. This happened because those materials and those registers were developed locally by community themselves. So sitting by the side of society is always what I say, not sitting by the side of science much, but sitting by the side of society is what will make even communication better.
Yeah, very true. Because I've also seen, like, there are a lot of these grassroots organizations who have been working with these communities, and they have adapted a lot of contextual information, into their practice. So one example that I can think of is JSS, the entire medicine packets about, when do they have to take the medicines. So rather than, writing about morning, afternoon, and evening, they have pictures, and these are all which are again developed from the community, developed from the context, which they're working in. It is coming from the people. So when we go in as experts and we bring in our expert information, they're more likely to fail. So as Mayur rightly pointed out, we need to sit with them, we need to listen to them, and we also need to check with them if these solutions that we come up with work, and that is very important for public health. So we have run out of time. We thank you all for joining in and pitching in with your questions, and thank you once again, Mayur, for this very insightful webinar. And we also like to remind our audiences that we would continue this discourse on public health through other webinars. And for those of you who are interested in our PG programs at the university, you can go to the website and you'll get more details on them. Yeah. Thank you. Thank you once again.
Thank you, Bevin. It was very insightful discussion.